Good afternoon and welcome to our session, a roadmap for managing post-transplant VOD and SOS, team-based guidance on capturing, assessing, and managing diverse presentations. So welcome. My name is Corbacioglu Duncan. I'm a pediatric stem cell transplanter at Boston Children's and Dana-Farber. I'm pleased to be sitting today with Dr. Salim Corbacioglu. And we'd like to really take our time to thank PeerView and the Medical College of Wisconsin for providing this session, and Jazz Pharmaceuticals for providing the educational grant for the symposium. You can view the slides and the practice aids now, and you can download them after the event at peerview.com, VOD Tandem 2025. So our first poll question, reflect on your practice and select the options you think represents a challenge or an unanswered question related to VOD management. A, understanding modern risk factors in the transplant setting. B, risk of VOD after gene therapy. C, when to use prophylaxis in pediatric and adult patients. D, making timely diagnosis in the absence of classical factors such as hyperbilirubinemia. E, calculating severity grading. Or F, timing and duration of treatment. Take a moment for voting. So there are a couple of 4 key points that we want to address today. 1, that VOD-SOS is a serious complication with mortality rates for VOD with multi-organ dysfunction or multi-organ failure as high as 80%. B, risk is not insignificant. The incidence of VOD post-allo transplant varies across studies with median incidence between 10 and 15%. 3, the need for post-transplant vigilance. VOD typically presents within 3 weeks of allotransplant, although late onset VOD represents up to about 30% of cases. And finally, particularly in high-risk settings, so in particular populations, particularly some of the pediatric patients, there are rates around 60%. There's been some new data in recent years thinking about how we practice transplant currently and that risk of VOD. And so this is a really fantastic study that was come out from this group in Spain, looking at 9 centers across Spain and treating almost 800 patients who received treatment between 2007 and 2019. And they're looking at the incidence of VOD after haplotransplant with post-transplant PSI. And so what they were able to find is that there were 46 patients out of this criteria who were diagnosed with VOD around 19 days, so pretty classic timing after transplant, but 44% of those had very severe disease by EBMT criteria. And the incidence after haplo with PT-PSI compared to those with HLA identical series was comparable. So our goals for today, we hope to provide you with guidance on using modern tools for VOD risk assessment, diagnosis, and severity grading. We hope to enhance your understanding of the evidence supporting modern prophylaxis and treatment. And finally, to equip you with the skills that you need to develop evidence-based VOD and management plans. And with that, I will turn it over to my colleague.
Thank you, Christine. First of all, thank you very much for having me here, and it's always a pleasure to meet old friends and make new ones, and also for the break of minus 3 degrees Celsius and fog for the last 3 months. It's my pleasure. Let's get started. Now, we have here 3 patients preparing for transplant therapy or gene therapy. And these are the cases that will accompany us throughout the talk, and I think with these cases we can learn a lot and adjust our understanding of VOD treatment, prophylaxis, and so on. So number 1, 2-year-old pediatric patient with neuroblastoma. He received 4 cycles of induction chemotherapy with immunotherapy, irinotecan and temozolomide, and now he's getting ready for a tandem autologous stem cell transplantation. Patient number 2, a 20-year-old thal patient. He qualifies for gene therapy, has an iron overload of 8 milligram per gram, and again, he's being conditioned with busulfan monotherapy. Last but not least, the 23-year-old patient with a Philadelphia negative BALL. He is progressing after chemotherapy, received blinatumomab as a bridging. Now he still is not in remission to go for transplant. He needs an additional course. In this case, he's receiving INO, preparing for transplantation. Now, with these cases, and I'm really addressing now the youngsters and the fellows in the room, because Now we have these patients, and we have to consider what is expecting us during transplant. What do we have to look out for? Is this somebody that has just off the road walked through the transplant and doesn't need any further care? Or are these patients that we at least need to earmark to be at high risk for a very severe complication that can really run away in front of our eyes within 48 hours post-transplant? And this is a scale that was nicely designed by Sarah Gerald. Excuse me. Sergio Gerald and Joan Hudal a couple of years back. It's helpful, but it's not really that helpful in our case. Here it says ferritin above 1,000 nanogram per ml, low risk thalassemia, kind of low risk. Then young age up to 9.5 years, low risk. Yes, of course, ozogomycin conjugated antibodies, high risk. But if our low risk thal patient with the iron overload of 8 milligram per gram by a liver biopsy develops bridging fibrosis, this patient is way up at risk for venoocclusive disease. And this beautiful publication by Strauss et al. From 2018 really highlights that venoocclusive disease is a pediatric disease and is a disease of infants. Now, let's take our infant. We are already way up, no matter what we do with these patients. And we know that these patients can even develop venoocclusive disease during primary chemotherapy for acute lymphoblastic leukemia, for example. Now we add high-risk neuroblastoma on top of that. That means tons of chemotherapy to get them into remission in high-risk cases, and a BU-based double transplant. So I think this patient is somebody that really is going probably even beyond this scale here. Important take-home message: there are cumulative risks that apply to these patients, and they add up to a very individual risk that we have to consider and recalculate for every single patient. Now, what do you think? In each case, what are the risks for VOD? What factors would we heighten your suspicion for post-transplant venoocclusive disease, and is prophylaxis?
I think those are great questions. When I look at these populations, and particularly the first patient, we see a lot of VOD or SOS and endothelial injury in general in the pediatric neuroblastoma patients due to their prior therapies. And so I think that that patient, just by age and virtue of their diagnosis, is high, along with the diagnosis of tandem transplant. For the thalassemia, I think the thing that stands out so obviously is that high liver burden and getting busulfan-based conditioning. And in the 23-year-old patient, the prior upfront treatment with inotuzumab and going into transplant. So I think that those are the factors that would really heighten my suspicion. And for all of those cases, I would consider prophylaxis. That's an individual, certainly center or your patient, but I think that the data that we're going to present would support prophylaxis in each of these cases.
Now, the next question is, and I think I alluded to that already, are there differences between adults and children? Because when we talk to our adult colleagues, I have even heard some who say, oh, VOD doesn't exist, or we see it extremely rarely, or any of those answers. Yes, there are differences between adults and children, and that's why also we highlighted the fact that we need criteria for children, just to not dump them into one pot, because differences are significant. Number one, there's a difference in the incidence, 2 to 2.5 times higher, at least. The incidence in adults is approximately 5%, kids 20, 25, even up to 60% in certain cases. We have definitely anecdotic venoocclusive disease in adults and children, but it's much higher in children, with up to 30%. And more patients have so-called unmodifiable risk factors, a genetic predisposition that they come into transplant with: HLH, osteopetrosis, if you want so, thalassemia, also patients that are suffering from neuroblastoma, but of course need some form of high-dose chemotherapy at an infant age. And infants per se, as we have seen before, are at high risk. So there's nothing to do about that. We also know that for whatever reason, the therapeutic efficacy of defibrotide is extremely high. Now, again, back to our residents and fellows on the floor who are going to assess a patient that's going for transplant. He has received several treatments, and here's the risk of unmodifiable and modifiable risk factors, nicely summarized by Mohammed and his group in 2023. So there's, not much really you can do about a second transplant. These patients have to go for a second transplant. I know you could consider to use inotuzumab or not in a patient that already comes in with a high risk, but if you're back to the wall, you're going to go with inotuzumab. Hepatotoxic drugs, you can avoid them, but in the end, what is really hepatotoxic specifically for veno-occlusive disease? That's something we really don't know, except for busulfan. Iron overload, over 1,000 nanogram per ml, doesn't really help much because our impression is that you can have a severe iron overload in your patients, but it depends on what this iron is doing to your liver. So this is an epigenetic factor here, where every iron in every individual patient, or iron load in every individual patient, can provoke a different response. In some patients, this iron is non-provocative, so these patients might have some mild fibrosis, and the same iron content in the liver of another patient is provoking a significant inflammatory reaction, bridging fibrosis and cirrhosis. So in those patients where you have a high iron overload, we recommend to do a liver biopsy to really assess the individual risk of this patient. Other side, modifiable risk factors. Busulfan, I think, is a risk factor. No matter if we do serum level measurements or not, busulfan is probably the major risk factor in combination, particularly with other risk factors, that you have to be aware of. Then it says high-dose triosulfan, and that's something I personally do not agree with. We're using triosulfan in combination with fludarabine and thiatepa for the last 15 years, and I have not touched busulfan in that time period. So probably I'm a little biased. But now you're lucky you have the availability to assess it yourself. Just to give you an example. Historical incidence of VOD in HLH, approximately 30%. And now we have two publications from 2020, one from Zurich, one from Hamburg, 25 and 60 patients respectively. Myeloablative conditioning, the only difference is targeted busulfan in Zurich, and Typhoon, my dear friend, is doing a very meticulous targeting of busulfan there. And on the opposite side, in Hamburg, FTT with triosulfan as conditioning. Incidence of VOD, 32% versus 10%. And as a little sidekick, incidence of VOD with prophylaxis, 20%, without prophylaxis, 5%. Number two, infantile malignant osteopetrosis, again, a whopping 60% incidence historically. Now, Shaduridol treated 31 patients, again, with FTT conditioning. Overall incidence of VOD is 0%. Our own experience with thalassaemic patients, adult and children that received a matched sibling or haploidentical transplantation with exactly the same myeloablative conditioning with FTT, the incidence is 0%, and we're going to publish that soon. Now, how about INO? 58 patients relapsed refractory BALL treated with INO between 2016 and 2022. Incidence of VOD, 29%. So let's consider a 5% average incidence. That's a whopping 6 times higher incidence for veno-occlusive disease with using inotuzumab. And what is really shocking is that 53% of the patients died of veno-occlusive disease, and that is fairly unusual when we expect a 20% severe VOD incidence. So there's something very toxic to inotuzumab that we have not really understood yet. What about VOD risk with gene therapy? We were the first group worldwide who had treated or dosed the patient with TDT with Casgevy, and we were surprised that our patient developed veno-occlusive disease, and now the overall incidence in the series of 23 patients is 13%. So now we're talking about a conditioning with busulfan monotherapy in a kind of high-risk population, and still there's an incidence of VOD that we have to take into consideration, although it's called an autologous transplant with lower risk, might not be true in this case here. Now this is the pediatric prevention trial that we published more than 12 years ago now, and it was run again 15, 16 years ago, that clearly showed that diphtherbetide prophylaxis in a pediatric high-risk population is advantageous with regard to the incidence of veno-occlusive disease, but we could also show that renal failure was lower, and the incidence of acute GVHD is lower. And so it looks like this is a miracle drug that can cure kidney disease and GVHD and veno-occlusive disease and everything. But I think the key to this story is very simple, and I think Ken mentioned it yesterday also. We're talking about the endothelium, and the endothelium must be seen as a catalyst turning point where the triggers come in, they're amplified, and then they developed that trigger-specific complications, starting from engraftment, capillary leak, VOD, pulmonary VOD, acute GVHD, and even PRES. We don't understand quite yet why one trigger going through the endothelium leads to one or the other disease. But in the end, it is all a systemic post-transplant vasculopathy. And the message here is just don't rock the boat, don't touch that endothelium, try to stay away from any aggravation that is going through vessels. Now, again, from our Lancet publication 12 years ago, we were surprised seeing that not only severe VOD leads to fatality, but also VOD per se. So mild, moderate, or severe VOD in combination with the transplant was associated with a 4 times higher mortality post-transplant. And these data were now corroborated by Drishta Ragunan and et al., who looked at a series of patients. And again, just the incidence of veno-occlusive disease is associated with a significantly higher mortality. So avoiding that disease, mild or moderate even, is beneficial for your patient. And here's a whole set of retrospective analyses and some prospective trials as well, looking at the incidence of VOD following defibrotide prophylaxis. They all clearly show that there is a benefit of using defibrotide with regard to incidence. In contrast now to the Harmony, to the pediatric prevention trial and all these mostly retrospective analyses, many people were surprised when the results of the Harmony trial came out. The Harmony trial was designed basically to confirm the benefit of defibrotide for prophylaxis in adults and children. But the result clearly showed there's no benefit for defibrotide prophylaxis. The endpoint was VOD-free survival at day 30 post-transplant, and that was a request of the FDA. Now, there's much to say about that trial, but in the end, the trial, I have to say, was doomed to fail from the beginning. The incidence of a risk-based, poorly selected patient population, number one, so they included adults and children. Incidence in adults was then even, so 10 years after the pediatric prevention trial, approximately 5%. And when we calculated the sample size for our trial, we assumed an incidence of 25%. At the end of the trial, the incidence in that high-risk pediatric population, 10 years back, no serum level measurements, no whatsoever, was 20%. The baseline for calculation of the sample size of the Harmony trial was 28% incidence in a combined pediatric adult population. So just from that point of view, the trial was underpowered. High overestimation of the expected incidence. Top, we had advancements in the field. We had high-resolution typing. We had one of serum level measurements that started after the trial was completed. And of course, we have drugs like treosulfan around that all reduce the incidence of veno-occlusive disease in adults and children. And then, on top of this, there was this independent, blinded evaluation committee, the EPIC committee, that came up with a VOD incidence in the defibrotide arm of 25% versus best supportive care 21%, and the investigators identified VOD with an incidence of 12% and 16%. So, number one, 25% incidence in whatever, 2020 in this combined population is impossible. That's far too high. We don't see that, number one. Number two is we can see on the investigator's side that this is more probably the real incidence when you combine the whatever 20% incidence in children and about 5% incidence in adults. And you also get a hint for the delta between 16% and 12%. But running that trial on the investigator side would probably raise your sample size to way over 1,500 patients to show that difference, that defibrotide might be beneficial for prophylaxis. Now, beyond incidence of VOD, I think we know that the earlier we intervene, the better it is for the patient. I mean, our clinical and diagnostic findings are fairly late, but we see that when we start early, in particular when we use prophylaxis, there's an advantage for not only survival, but also morbidity. And this is shown here nicely in 58 pediatric patients that were treated between 2008 and 2022. Patients that received defibrotide prophylaxis nevertheless develop veno-occlusive disease at a lower severity of disease and accordingly shortened hospitalization and shortened treatment period. And these are data from my friend Christoph Kalbach from Wroclaw, who analyzed a set of 551 patients, again comparing patients that develop veno-occlusive disease with and without prophylaxis, and again confirming that there is the aspect of morbidity beyond the factor of incidence with regard to different type of prophylaxis. Lower hospitalization, lower admissions, reduced admission to the ICU, less use of blood products, and the timing of post-transplant bone marrow recovery are all aspects that are important with regard to different types. Now, next question. How does the onset of these symptoms reflect the course of VOD development in pediatric and adult patients post-transplant and post-gene therapy? And what's the role of modern criteria in capturing VOD SOS, and how have they enhanced previously used classic criteria?
So looking at this, so how does the onset of these symptoms reflect VOD development in the pediatric adult patients and post-gene therapy? I think when we look at those cases, seeing in the 2-year-old patient having now increased frequency of transfusion, so sort of hinting at refractory thrombocytopenia, weight gain despite fluid management, increase in girth and supplemental oxygen, those feel very classic to me, especially at a time when this occurs after day +8. So I think that that falls very much in line with what I would expect. I think when we look at the 20-year-old patient, so this is a patient who has, on day +8 after infusion, increasing delirium surveillance scores, and then on day +12, a bilirubin increase from 4 to 6 with increased transfusions. I think really a key point about this one is for that thalassemia patient, as we looked at earlier, coming in with a higher iron burden, that's going to put that patient at risk. And I think a bilirubin of 6 would certainly raise a lot of eyebrows and get people's attention. And finally, the 23-year-old patient who had progressive multi-organ failure, a tripling of the creatinine, oxygen requirement in hepatic VOD, and coagulation replacement. I mean, I think that that is a very rapid onset of VOD, which we see in sort of highlighting the difference in clinical presentation you can see. Though it may be difficult in this case because it is so fulminant to think about many other things that could be doing this. Could it be sepsis? Could it be something else? So I think a lesson there is to try to keep VOD on your differential. And then the second question, what is the role in modern criteria in capturing VOD, and how have they enhanced the previous classic criteria? I think there's been some real advances in recognizing things that are outside those original criteria. So refractory thrombocytopenia, looking at the time of onset. And one of the things that I think has been one of the greater strengths about that is separating out pediatric versus adults patients. And I think it's sometimes a little controversial. People ask which criteria do we use at my center. And sometimes I'll say, we don't necessarily, we're not around checking these things off and going through them. And I know some centers need to do that to get prophylaxis if you need to get it, or treatment through a pharmacy therapeutics or other committee. But what I really find valuable is that those criteria help us remember what to think about and what to see in a very modern setting.
Thanks, Christine. So, clinical and biochemical signs of VOD and severe VOD. I think we don't have to really walk through the signs and symptoms. Shortness of breath is highlighted as probably as a second organ in many patients that are hit. So we're talking about multi-organ failure, indicating that this patient might become a patient with severe VOD, but at the same time, in an infant, it could be simply a large amount of ascites that is compressing the lungs and that you can really get easily rid of by a paracentesis and releasing that fluid from the belly. Now, lab values, important here. When your transaminases are rising, this is a secondary consequence of now hepatocytic disease. So we're not talking about an endothelial disease. Now we're going into the second level. We're hurting basically the original liver cells here. And that's something that we should be aware of, that this is not a good sign for an easy course of the disease. Same for coagulation factors. So the productive capacity of these hepatocytes is decreasing. And refractory thrombocytopenia is listed here as a severe sign. Yes, albeit it is really the earliest sign you can see for diagnosis of VOD. Persistent refractory thrombocytopenia just tells you that the damage of the endothelium is ongoing. And Ken, yesterday during his talk, mentioned Velcro. Being European and loving Parmesan cheese, I call it a Parmesan grinder, rather, because that gives you the idea that these platelets are destroyed on the endothelium, and at the same time, the endothelium is getting leaky. So everything is accumulating in the space of DC. And if this goes on, you know that this is still an active disease and that you have to be aware of prolonged hospitalization, ICU admission, and so on and so forth. Good. Now, based on what we have said, we have now the revised adult criteria that are basically reflecting Baltimore as early onset up to day 21 or late onset, which is more or less Seattle criteria. And next to that, as I mentioned initially, we thought that we really need pediatric criteria for all the reasons that I mentioned before, and we introduced for the first time refractory thrombocytopenia. So how do we understand refractory thrombocytopenia? A patient needs a platelet transfusion one day, early post-transplant. The next day, the patient needs another platelet transfusion. We don't really care much. A patient needs a transfusion, we give him the transfusion. On the second and latest, on the third day, I guarantee you, your nurse will come up to you, will say, look, I'm running into that room hanging out platelets every day. Something is wrong here. And these 3 days are fair enough for you that you can consider that there is something is going on that is consuming platelets. It could be a sepsis that's easily to disclose, or it could be that this patient has LA antibodies. So you do your 1 hour count, and if the platelet numbers are rising appropriately, this patient is consuming these platelets. And at that point, latest, you really should consider VOD as your differential diagnosis. It's very simple. Next criterion, we omitted the 5%, 2%, 3.7% weight gain. There's no evidence for any of those numbers. So we said that if you do a meticulous fluid management and your patient is still gaining weight and is still third spacing, that is an ominous early sign. And in the skinny little ones, an abdominal girth is a very sensitive tool in the hands of your nurses. And hepatomegaly and ascites, of course, it has to be based on a baseline ultrasound that really can verify that this patient has an increased liver according to baseline or is accumulating fluid. In particular, again, in children, because these patients come in with hepatomegaly and ascites in many, many diseases, such as HLH, osteopetrosis, and thalassemia. Now then we have here the refined diagnostic adult criteria that I will not delve into. They divided now in probable, clinical, and proven, added the addition or added the elastography and other hemodynamic profiles in that picture. And I'm really hoping that we can get an improvement from the previous criteria with regard to sensitivity of these criteria. Then here we have the Cairo and Cook criteria that Kenneth presented yesterday. And it's basically a combination of pediatric and adult criteria and Baltimore criteria. So we have the hyperbilirubinemia of 2 milligram per deciliter, still the weight gain of 5%, but we have also excessive platelet transfusions post-transplant, so refractory thrombocytopenia, right upper quadrant pain, but we have also biopsy and unexplained elevated portal venous wedge pressure in that setting. Now, mind you, and this is very important, and this is also what I keep telling to my residents, is it is not the radiologist who diagnoses VOD. So if the patient gets his ultrasound and the radiologist says, I don't see reversal of flow, this is not VOD, just ignore it. It's only true if he says, I see reversal of flow, and then you can be upset with yourself because it's a very late finding if it occurs at all. So even very severe patients with multi-organ failure can come up with anicteric veno-occlusive disease and no reversal of flow. Here's a summary of the modern diagnostic criteria. The pediatric criteria deliberately excluded biopsy because it's dangerous, associated with a significant bleeding post-transplant, and the Doppler ultrasound for reasons that we don't see really a reversal of flow in many of those patients. Now, graphic look. Baltimore criteria, we said this obligatory hyperbilirubinemia is a late finding, and evidently it is associated with significant mortality in adults and children, and the dotted line reflects the fact that there's a lot of anicteric veno-occlusive disease in children, so if you wait for hyperbilirubinemia, you might also be waiting for Godot. Seattle criteria, no obligatory hyperbilirubinemia, so you might have a chance to come in earlier with a diagnosis of veno-occlusive disease. And of course, you might rise by changing these criteria, the incidence of veno-occlusive disease per se. Then we have the new adult refined criteria. I put them right there. There's, of course, no evidence for this. And then we have here the pediatric criteria, where I really have to highlight that the really earliest sign we see is refractory thrombocytopenia. Just keep an eye on that, assess it for yourself, but it's extremely helpful to really get this patient earmarked for treatment. And last but not least, we have the Cairo criteria here up that, as I said, have a combination of everything. So everybody can feel happy with the Cairo criteria. You have the ultra-Orthodox, aggressive people who say, we don't believe in VOD, we need a biopsy. They can diagnose a patient according to the Cairo criteria. And if you have the other ones on the opposite end that say, okay, we believe in early intervention, they can go with right upper quadrant pain and refractory thrombocytopenia. So that's the major difference, I think, between those criteria. And then accordingly, you can have totally different incidences. Now here, just comparing Baltimore with Seattle, at least the incidence is doubled or quadrupled. And let's say you use the Cairo criteria in two different institutions. One is very hardcore, non-believing. The other one is very, I call it soft or very, very aggressive with treatment. You will have an incidence difference, at least by 4 times. And accordingly, also the severity of the diseases might be different. When you go for biopsy and hyperbilirubinemia, mortality and morbidity might be higher. And this is something that we have to be aware of. Then there's E6 criteria and elastography. I have no evidence for sensitivity yet if this is useful, but I think we know that 48 hours can make a huge difference between diagnosis and starting defibrotide. You probably do your elastography every day, every other day. You might have a chance to catch up there. And then there's this gap, and this gap marks a question mark that says, is there still space for prophylaxis? So are those criteria really sensitive enough to diagnose every patient early enough, or do we need prophylaxis in those patients? Now back to our cases. Modern criteria allow for greater sensitivity and earlier diagnosis compared with Seattle and Baltimore, and can be used to inform grading and early use of supportive care and defibrotide. Now, back to our poll. Would you consider prophylaxis for this patient? Now it's our 2-year-old with neuroblastoma for tandem transplant who presents with multiple risk factors for VOD. Here we go. Thank you. I think that's also what we would do in this patient without any question. Next question. Rethink your choice. In general, how would you characterize modern criteria, Cairo or EBMT criteria to diagnose VOD? Similar to classic criteria? Similar to classic criteria, but can capture anicteric and late onset, able to capture late onset and anicteric, including refractory thrombocytopenia. And I'm unsure. You're not unsure. C, able to capture late onset and anicteric, including refractory thrombocytopenia. I think we're done. We can go home now. That's it. Thank you very much.
Okay. Excellent. So in this portion of the presentation, we're going to talk about guidance for assessing disease severity and deploying timely treatment in patients with VOD. And so now we're returning to those cases. And so for our 2-year-old with neuroblastoma, we now see that this child has a peritoneal drain in place. We see for our patient, our 20-year-old patient, the bilirubin and the frequency of transfusion is unchanged. And in our final patient, we see similar or the same what we saw multi-organ failure. So our discussion questions. So the ALL case is very clearly severe. How can we characterize the severity of the neuroblastoma case in thalassemia patients, and what were the limitations of the older grading systems?
Well, Christine, I think we now know that infants are really an issue. And just starting from there, knowing that the high-dose chemotherapy is damaging these tissues substantially, there's probably no question that this patient really needs attention, needs early diagnosis, and as we said before, really should go for prophylaxis, because as we all know, leukemias come in Friday afternoon and VODs come in Friday afternoon, where we all are gone, and we leave the floor to the poor young residents, and I think that is detrimental. Then the thalassemia case is an interesting story, because when we came in there, we thought, okay, autologous transplant and monotherapy with busulfan, but apparently this combination still seems to be a tricky one. And I'm really waiting for the real world data when the treatment is out there, since it's licensed now in centers that don't really see much of VOD. And I think there might be even increase of veno-occlusive disease when the treatment is out there, and then people are not as meticulously sitting on top of these patients as you do during the trial. Grading, well, the grading doesn't really impact on or is not impacted by the risk factors. I think with the grading, it is really important to see how the disease evolves. You can follow, of course, the rise of the bilirubin, the consumption of platelets, and the accumulative damage occurring to the coagulation system or fallout of other organs. And I think that really should guide your treatment. And I always say that you should start when you diagnose the disease, because the course can be so fulminant that even a mild VOD today can be multi-organ failure within 24 to 48 hours. And it's like every day you run behind with initiating the trial, you lose 10 to 15 days later on to get the patient off again.
Absolutely. Thank you. And maybe I could just ask one follow-up question about that. I practice at a center where we are very proactive about placing peritoneal drains, particularly in the young patients, thinking that allows them better, and sometimes in cases keep them out of the ICU, allowing them to have more expansion. Is that a similar practice, or how do you handle peritoneal drains?
Absolutely. The peritoneal drain is an interesting and very, very efficient tool that you don't have to be afraid of, because you basically separate pulmonary disease from secondary compression and secondary pulmonary affection, which is important because it is still then a one-organ disease and not a multi-organ failure that puts the patient into a different category.
So I just want to go over the updated EBMT severity grading in adults. And so just to highlight a couple of things here. And so we see categorized by the time since VOD or SOS diagnosis, bilirubin, the bilirubin kinetics, so the doubling of that bilirubin, which can be particularly helpful in patients who come in with a higher bilirubin, like our thalassemia patient. Transaminases changing, and as Salim told us, this is a later finding because now you're at a hepatic injury rather than the endothelial or sinusoid itself. And the weight increase, which is present in the adult criteria, but as we'll show, the severity grading, but different in pediatrics. And just for a practical matter, if you are grading, and there's two risk factors or two findings, they should be graded in the upper grade. So if someone has one finding that puts them moderate and the other severe, you would place that patient overall in severe. There is more detail, perhaps, or more nuance in the grading of children, particularly related to many of the issues that Salim presented us with. And so highlighting up at the top, we see that persistent refractory thrombocytopenia being present, the GFR, so we're looking at your kidney function, changes in the neurocognitive status, so many things here trying to get to that point. And again, pointing out the need for paracentesis or that external drain, particularly in a very small patient, can be something that helps to prevent progression, I think, at least in my experience. I think these revised VOD multi-organ severity grading can also help overcome some of the limitations of prior ones. So we look at what is probably or directly attributed to VOD, some of these changes, we can look at ascites and the symptoms and the interventions, and they're clarified those pieces. We can look at the cardiac outcomes. We can look at weight gain as a change not from baseline, but from a recent with meticulous fluid management. So I think that the grading systems have also helped to refine some of the diagnostic, or are refined based on the newer diagnostic criteria. And as I've said, grade is defined by the maximal organ severity damage, with 0 being no VOD and grade 5 being death. And so coming back to our patients, I'd like you to think about how you would manage these patients. So if you're the person in the room, if you're the person on rounds, how would you manage these patients? So would you do, and we'll turn to you as well, supportive care, first to see if symptoms improve, supportive care and defibrotide at the same time? And is there an agreed upon definition of timely therapy? Should you watch? Should you wait? Should you support? Should we start within a day? Should we start within 2 days? And what is the expected time for VOD resolution and improvement in each of these cases? So we'll start with, so what would you do? Supportive care to see if symptoms improve, or would you support meticulously and use defibrotide therapy?
Well, as I said, if we diagnose VOD, you start treatment, you add your supportive care. And as I said, the earlier you start, the earlier you can stop.
I agree, and I think that answers that second question. I don't know if there is a consensus or uniform timely therapy, but we know, and we'll show some of that data, that earlier treatment is associated with better outcomes. And then that third point, what is the expected time for VOD resolution and improvement in each of the cases that are listed above?
Well, there are 2 points. Number one is we put up some set of criteria that we call dynamic and static. Dynamic criteria are those that we use, for example, refractory thrombocytopenia, and the ascites production. These are dynamic criteria. So if the patient suddenly maintains his platelets for 2 days and then 3 days, this disease is calming down, static criteria are hyperbilirubinemia and hepatomegaly. So if you're not waiting until the bilirubin comes down to 0 or the liver size is decreasing, you can stop or wean defibrotide and watch the patient. And if you see that your dynamic criteria are not active anymore, you can be safe and stop defibrotide. So the 28-day treatment that is in the product information sheet should not be your guidance. And again, the earlier you start, the earlier you can stop.
I agree. So we'll talk now about the current options for managing VOD in the post-transplant setting. So defibrotide, known to many in the room, this is an FDA-approved treatment for adult and pediatric patients with hepatic VOD and renal or pulmonary dysfunction after transplant. And that's based on the original pivotal trial. Supportive care, diuretics, fluid salt restriction, paracentesis, hemofiltration, mechanical ventilation, and others are really critical for the care of patients with a VOD. And while some of these things vary from center to center, I think one thing that doesn't is the real importance of the interprofessional management team. And so for a paper from Kristen Mangata in 2023, we see sort of the interdisciplinary team, your physicians, your pharmacists, nurses, everyone who is there, and the multidisciplinary, and the teams that get involved at a time point. And of all of these really important people, there are 2 I want to highlight, and the first being the pharmacist. We're not speaking much about it today, but as we see hepatic dysfunction progress in patients, you think about their ability to clear sedating medications, about their ability to handle their calcineurin inhibitors. One of the things that we often see is patients where their calcineurin inhibitor levels are going up and up despite any changes. So I think really involving your pharmacist in your care of the patient, and then the dietitians and the nutritionists. So this is a period of time where patients will have change in their metabolic need and really meticulous care and watching those things. So not one of these is more important than the other, but it's really important that we all work together. And so I want to highlight the older trial, so the treatment investigational new drug trial of over 1,000 patients to show survival, that investigated survival at day 100 in patients who had multi-organ dysfunction or not in adult and pediatric transplant patients. And so the estimated day 100 survival for 1,000 patients with documented defibrotide therapy was 58.9%. And when you look at the figure, you can see that VOD, the top one in the blue, is VOD without multi-organ dysfunction, and not surprising, VOD with multi-organ dysfunction having inferior survival. These findings held up across pediatric and adult patients, and you can see the pediatric patients just overall had a more favorable survival compared to the adult patients. And I think that is reflecting the patient population rather than perhaps the VOD management or just the resilience or organ resilience in children. The DEFI-France criteria and the EBMT PASS registries address VOD and show that highlight that addressing VOD confers a benefit regardless of severity. So just to orient you to this slide, we see the adult the adult patients on the left and the pediatric on the right. The dark blue bar represents severe VOD in the percentage of survival in patients who have severe VOD with resolution, and then in the light blue, severe VOD without resolution. So showing your survival if you fully treat, is superior. And in the orange, the non-severe VOD. So this is non-severe disease, not these multi-organ failures. And the patients in the orange who had full resolution compared to green, those who did not. And then you look at those pediatric patients, and you can really see the difference in survival. So patients with the dark blue, if your VOD does not resolve, and compared to those in the pediatric. In the orange, we're looking at patients with non-severe VOD and incredible survival numbers approaching 100%. And so regardless of that disease severity, the survival at 100 was higher in both patients, adult and pediatric, when you had resolution of your VOD, sort of highlighting, regardless of severity, we should all be striving to treat VOD to disease resolution if we can. So other really important information from this study looked at inotuzumab and gemtuzumab therapies in a large number of patients. And to summarize the results of these almost 462 patients, of those, 12% received inotuzumab or gemtuzumab prior to their transplant, and we looked at their outcomes. So the key take-home point for this, and you can look at the non-VOD patients versus the VOD patients and see the differences in their survival, certainly, but the VOD time and resolution and their defibrotide treatment duration was similar in patients whether you got inotuzumab or gemtuzumab or those who had VOD without it. So highlighting, you need to get on top of those patients. These patients can survive. They do survive in many cases, and that is often hinging upon very rapid diagnosis and treatment. And Celine mentioned this, and I think it is really incredibly important data. And so this figure reflects the publications on the bottom and other work by many people that have shown initiation of defibrotide closer to VOD diagnosis is associated with better outcomes, including day 100 survival. So just thinking, you don't have to necessarily be 100% convinced. You don't have to have every single thing to start treatment. You can stop treatment if something else changes and you've learned that there's something else contributing to those symptoms. And so, for example, in one of the studies, we saw that initiating treatment less than or equal to 2 days post-diagnosis is associated with better survival even compared to 3 days or greater than 3 days after that time. So earlier therapy leads to overall better outcomes supported across multiple different studies. And now we look at those different criteria we've spoken about. So the pediatric EBMT diagnostic criteria compared to the traditional criteria. In the orange are the EBMT criteria, and the blue are traditional. And across the board, we can see that the VOD incidence was higher if you use EBMT. Defibrotide response rate was also, though, higher, and that was a significant finding. Overall survival higher using EBMT, and the transplant-related mortality lower. So the question is, why is this? And I think this is really hinging upon time to diagnosis. So in the diagnosis with the modified Seattle criteria, it was delayed 0 to 11 days compared to the patients receiving EBMT. So EBMT, you are diagnosed earlier, likely reflecting better outcomes. And then finally, looking at bilirubin, this is a poor prognostic indicator. It's rather than bilirubin greater than 2, greater than absolute number, then should be used as a diagnostic criterion. So we see the estimated day 100 survival rates on the top, pediatric patients who have a bilirubin less than 2, approaching 100%, adults with a bilirubin less than 2, 64, pediatric greater 76, and greater than 2 in the adult 44%. So really making a tremendous difference. So try to diagnose early so we're not getting to those points. And then finally, questions come up a lot on timing about real-world safety. So I just want to hit, and this is based on the DEFI-France registry about the safety of defibrotide, and we can look up here in the pediatric and the adult patients and overall. What I really want to highlight here is that risk of hemorrhage. We often hear about the bleeding risk for VOD, and I can refer you back to the prophylaxis trial where you've seen that actually the risk of bleeding was higher in patients who didn't get defibrotide compared to those who do. And while there is certainly a risk, if you look at some of that data, viral hemorrhagic cystitis and hemorrhagic cystitis not likely related to defibrotide. So I'm not advocating for a hemorrhaging patient getting defibrotide at that time, but also to be more, in my opinion, more aware of uncontrolled severe VOD rather than using the drug, and certainly make adjustments in your supportive care to account for that. So some real practical management considerations. We see the dosing on the top. It is contraindicated when you have systemic anticoagulant or fibrinolytic therapy. That does not mean you can't use it if someone's getting heparin for their central line maintenance. Severe hypersensitivity, stop. And that's incredibly rare. Bleeding in a first episode, whether it's related or unrelated, hold, treat the bleeding, and consider resuming once the bleeding is stopped and if the patient's hemodynamically stable. Recurrent bleeding, permanently stop. And if there's an invasive procedure, discontinue at least 2 hours prior to the procedure and resume post if there's no bleeding. And so other considerations, Salim, just for you, would you initiate defibrotide in the setting of refractory thrombocytopenia?
You put yourself in between a rock and a hard place, right?
Yeah.
But in the end, what we do is we try to fix the coagulation factor deficit, number one. Defibrotide has an extremely short half-life, like heparin, so there's no damage done using defibrotide. So we try to really transfuse the patient and as much as possible continue to use defibrotide, because in the end, it is not going in the right direction, stopping the drug, because you're only left with one single drug to cure this disease.
And so for our final poll, now that you've seen the session, reconsider the young adult patient who has beta thalassemia treated with busulfan conditioning for gene therapy, who presents at day plus 12 with confirmed VOD. What would you do next? Initiate supportive care immediately, supportive care plus defibrotide immediately, initiate supportive care, then add defibrotide if symptoms worsen, or monitor for worsening symptoms, and then treat immediately with supportive care and defibrotide. Oh, good. Thank you for listening as we went through the day. And so, in summary, for these patients, the patient with neuroblastoma received supportive care and had resolution after 14 days of treatment. The older patient had resolution after 21 days, and the patient with B-cell ALL after 30 days. And we are running up on time, but we do have questions that we received from the group. Maybe I can comment on, there are two of them about gene therapy. And the question is whether VOD that develops after gene therapy is more severe than that doesn't. That doesn't appear to be the case. We have not seen that. And just to highlight that most of that VOD, if not all of that has been seen in that gene therapy, comes in the setting of thalassemia patients, so a patient that's already enriched for population, enriched for VOD. So just to think about that piece. And there was another question asking whether you would, in that particular thalassemia patient, decrease your myeloablative conditioning for gene therapy to reduce that risk. And I think the answer is no. At this point, you're trying to highlight, with gene therapy, we're not at a point where we know you can reduce the intensity and still get those cells in. So I think in those cases, you have to favor getting the cells in, getting engraftment over reducing your conditioning for risk of VOD. Other questions over there you'd like to answer?
Yes, there's one question that says, is there evidence supporting the use of short-course defibrotide in pediatric VOD? Of course. I think we have to set our mind to what we usually do in transplant. We start broad-spectrum antibiotics in patients with fever and neutropenia. We don't really treat sepsis, evidently. We are starting to use horrible drugs like encyclovir in rising viral titers. These patients don't have really viral infections at that time point. But when it comes to VOD, we need evidence that this is really severe VOD before we start treatment, knowingly that preemptive intervention is definitely better for the patient. So here, what is our problem if we overtreat some patients with a drug that is particularly absolutely benign when there's no VOD around? The advantage is you have a head start with those patients that develops symptoms later on, and in those patients with VOD, within 3 to 4 days, 95% will develop the classical whopping VOD Baltimore criteria. You can be safe that you started early. Stopping early, sure. You start the patient, and 5 to 6 days later, the patient does not progress. You can stop immediately. If you have a patient that responds quickly, and we just published a paper on VOD in first-line ALL treatment. So these 7 or 8 patients that we published developed severe VOD with, the whole shebang, everything they can expect. But they responded so promptly to the treatment that was totally flabbergasted that we stopped treatment after 2 weeks. They went home, they're doing fine. Sure, so you really have to watch the patient. It's not the 21 days, it's rather the patient that tells you where to go and what to do.
Then maybe just two last questions. We'll address one of them because it's been asked multiple times. Is there any role for steroids in VOD treatment? I can comment on that. I think I know that there's a paper, I believe, coming out of Cincinnati highlighting their experience using steroid. But I think that to my recollection, is the limit of the extent of that disease data set. So perhaps watch this space, more information to be learned about that. Oh, I'm sorry. Couldn't see you over there.
Hey, Steve Grubb, CHOP.
Hey, Steve.
Great session. Really appreciate it. So a couple comments, really. One is, one of the least fun things I've ever done is go to the ASH meeting and present the results of the Harmony trial, but the results were negative. It didn't work. Now, if you go back to the problems with the trial that were outlined, I think those are all well taken, but and clearly the external adjudication committee created VOD that the clinicians at the bedside didn't see, and obviously that wasn't a real thing. But if you go back and reanalyze the data based on what the clinicians thought, whether the patients had VOD or not, it doesn't rescue the conclusion that there still was not an evidence for efficacy in that situation. So especially in the United States, I know things are different in Europe, it's really hard to argue. We're treating all these thal patients with single-agent BU for gene therapy. Should we be using prophylactic defibrotide? And to be honest with you, we're not. But the key is to jump on it early, as you guys have said multiple times. I think the other thing that I would say that we've had the most trouble with is, and you mentioned this briefly, Salim, and I just want to emphasize this, is patients with true refractory thrombocytopenia. What does refractory mean? They are 6 when you give them platelets, and they are 6 when you're done giving them platelets, and you want to give them defibrotide, and it says you have to be over 30, and that is absolutely impossible, and you just got to deal with it. And I think the thing I have the most trouble with is arguing that particular point. And then sometimes if the INR is off, how much FFP do you want to give a patient who shouldn't be getting a lot of salt? It's probably not that helpful to try to fix it. But people think you have to fix the number to give the drug. And I know you would 100% agree that that's not the case, right?
Absolutely.
Agreed. Yeah. I think so. Thank you, everyone. This was a fantastic. These questions are amazing. I'm sorry we couldn't get to all of them, but please come speak with us, and thank you for joining this session.